point which will cause disease in humans and also in mosquito. The best part of it is it can undergo asexual and sexual also. So there are various type of plasmodium. Okay, in among them we are studying about the vivax, ovarian, falciparum and malaria. Yesterday we have discussed about the tertian, malignant tertian and the quarter. And we have discussed how this malaria can present. Okay, this disease can be due to the anemia which has caused or hypertension which has caused or due to the toxic products which will be released during the breaking down of its hepatocytes or the RBCs. Okay, so all these symptoms are seen. So life cycle, as he explained, we are first speaking about the sporozoites, then merozoites, then entering the erythrocytic stage. Okay, here we have hypnozoites also. Erythrocytic stage, we are telling about the ring shape, the ring structure of this RBC. Okay, within the RBC we see a ring structure. Then again they are converted by cyzoloni. Then the trochozoites are released. Okay, here we call them as trochozoites. Again, the trochozoites and the merozoites, they enter the RBCs. Okay, so again a part of it will go for gametogenesis and the reinfection takes place. So we have erythrocytic, both the stages here. So the drugs here are 4 aminophenolines, okay, chloroquine, hydroxychloroquine, amodiaquine, piperaquine, 8 aminophenolones. They have relatively different structure and they are mostly used for the radical cure. Okay, the radical cure word should be remembered for this Primarquine. Okay, Primarquine 45 mg for falciparum and 15 mg for 15 days for ovarian and malaria. Okay, so the newer generation ones are less toxic compared to Primarquine. What we are worried about Primarquine? In case of G6PD deficiency, it can cause anemia, okay, hemolytic anemia and teratogenic also. Cinchoalkaloids, we told that quinine was the first drug which was used, and we told about the World Wars that the Germans started with chloroquine or the rosacine which made them to synthesize this. Okay, quinine or quinine is the was the classical drug obtained from cinchona bark. Okay, so quinine, methanol, mefloquine is the relatively slower acting compared to the chloroquine, but compared to other drugs, it is the faster acting erythrocytic cyzonucleoside. Only reason why we use it is mefloquine is mega. Okay, mega means it can act for longer duration of time. So TRP is around 15 days. Okay, so then we have this bicarbonate, proguanil and chlorproguanil. Okay, they are involved in enhancement of the drugs used along with them. Okay, so diaminophylidines, we have pyrimethamine, sulfonamides, and like sulfadoxine, sulfadapsone. These are the drugs which are used in combination with pyrimethamine. These are the actually we should have kept it as together. Okay, so sulfonamides plus pyrimethamine. Why we use them together? Sequential blockade of the folic acid synthesis. Okay, so diarrheoteroid synthesis, then the tetrahydro, sequential blockade will be there. Okay, then we have this antibiotics. Okay, these are again the drugs for the chloroquine resistant malaria. Okay, these are the drugs for chloroquine resistant malaria and not used on a regular basis. Okay, these will be the reserve drugs: tetracycline, doxycycline, clindamycin, and all. So naphthopinone, the atovaquone, which inhibits the ATP. Remember, ATP. Then cis-quiterpene lactose. This is the drugs of this decade. Okay, artesunate, artemether, arteether, and arterolane. Okay, so amino, today we will be learning about these things. Amino alcohols, that is alpha-phentrine, lumefantrine. We already know the mechanism. They act by similar mechanism as chloroquine. That is the prevention of formation of non-toxic chemozoe. Okay. Yes. What's up there? What better business you have with that? See, don't give it that. Open it. Give it to me. Fast. Give it. Details. Work out of your class. So we have this amino alcohols, that is the haloperidine and lumefantrine. The next drug is naphthalidine or pyronardine. Okay, pyronardine, haloperidine, mefloquinone, chloroquine. See, these are all the drugs which prevent the formation of hemozoe. Okay, so these are the drugs. Okay, then chloroquine, we have just discussed the most of the parts. Okay, the drug which is safe in pregnancy. Okay, remember, chloroquine is a drug which can be used safely in pregnancy. Okay, the prototypic drug of this anti-malarial drugs. Okay, so they act on the exoerythrocytic stage and also the gametocytes. All site of action is there except for action on the hypnozoites. Okay, so this is the steps. Okay, chloroquine, quinine, mefloquine, lumefantrine, pyronardine converted to hemozoe. Okay, so pharmacological actions here, we know that chloroquine is a drug with anti-inflammatory property. Okay, so anti-inflammatory property, antihistamine, that's what we need in case of the toxin release. Okay, so anti-inflammatory, antihistaminic and local anesthetic action also. We never use it for that. Okay, so the resistance here is by efflux mechanism. Okay, so most of these parasites are now well versed with chloroquine when used alone. Okay, so we need to be careful. We are now using a combination based therapy or RT medicine based therapies. Okay, so we told that one of the next question that we need to answer it as liver rather than the retina. Okay, so this is the dosage forms. Today we will be learning about this. Adverse drug reaction starting from the hair, disconnection in the hair, then CNS toxicity, then ocular toxicity, then cardiac toxicity, QT prolongation, GI upset because it can be used orally, then hemoptysis, that is the thrombocytopenia, agranulocytosis, all these things are there. Okay, insomnia, CBS, all these things are there. So therapeutic uses, there are a lot more compared to the other drugs. Okay, so it is the drug. Most commonly we use it for this malaria. Other than that, we find its use in rheumatoid arthritis. So hepatic amoebiasis, rheumatoid arthritis, most commonly used. Others are the discoid leukocytomatosis, infectious monocytic cyst, all these things. So 4-aminoquinones. Again, we have hydroxychloroquine, most commonly used for the purpose of rheumatoid arthritis. Okay, comparatively less toxic. So amantadine, similar drug. Quinine. Okay, so this is the drugs from synchronalkaloid. It has more cardiac toxicity also, but also has a plus point used as a first-line anti-arrhythmic drug. Okay, the drug is commonly used in cerebral malaria. Okay, so the TRP is around 10 hours compared to the chloroquine, it is less. So it can be used for the gametocyte for virus and malaria. Okay, so cardiac toxicity will be there, hypertension will be there. Where it can be used? So the drug here can be used for other than malaria, myalgia, congenital, toxoplasmosis grams, sparglicidin, vaginophrines, and here the cardiac condition is not written, okay, as it is benign. So synchronism, you need to remember, it affects the vestibular system. So vestibular system, the balance of the person is affected. Tinnitus will be there. Okay, ringing sensation, tinnitus, visual disturbances, hearing disturbance, all these things will be there. And even at higher doses, it can cause respiratory depression and cyanosis. So idiosyncrasy, cardiac toxicity, all these things are there. So primarily we told it is a drug, it ends with pain, but the mechanism of action is the free radical injury or reactive oxygen species. Okay, so here we told about the adverse effects which it can cause due to the patient with B6 phosphate deficiency, and also the glutathione mediated reaction is also affected. Okay, so tetracycline and amantadine are relatively safer compared to the primarquine, but still to be used in practice. Mefloquine, Everything is same. You need to remember everything as like chloroquine, except you need to remember the last line. Neither gametocyte nor hits the hypnozoites. That is also, this part is similar but not good enough as chloroquine. The plus point here is meglopin is the longest acting, and we have the best drugs, that is the artemisinin derivatives, which are the shortest acting drugs among them. Okay. So the longest and the shortest are married together to form the long acting drugs or artemisinin based therapies. Okay, so pharmacokinetics here, meglopin need to remember 2 to 3 weeks. Okay, so it can be concentrated in the liver as with chloroquine. Okay, high plasma protein bindings. Most of it is similar. Okay, so effective in MDR, that is multi-drug resistant falciform. Okay. So adverse effects, you can just quote it as like our chloroquine. Haloperidol and lumefantrine, we told that their mechanism is similar. That is the blockage in the conversion to chemozoin. Okay. So atropine, remember ATP. Okay. So it collapses the mitochondrial membrane, interferes with ATP production. It is a synthetic naphthophenol, rapidly acting erythrocytic sesamotripside for falciform and also for other plasmodias. So it is effective in A, you can remember as malaria, T for toxoplasmosis gondii, and P for pneumocystis zerovis. Okay, ATP, it prevents ATP and it is also used for ATP. So the next drug is proguanil. Okay, proguanil is a adjuvant drug. Okay, it's a biguanide converted to cycloguanil with active compound, slowly acts on the erythrocytic stage of the vivax and the falciform. So adverse effects are in the form of stomatitis, mouth ulcer, large viscous depression. Okay, it is again an adjuvant drug which can be used along with the other drugs. You can depress the myocardium, megaloblastic anemia, all these things. This depression of myocardium and megaloblastic or the chemotoxicity is somewhat similar to most of the antimalarial drugs. Okay, so here it can be used for 100 to 200 mg. So the next combination is sulfonamide plus pyrimethamine. Okay, so previously once the chloroquine resistance was found before the advent of artemisinin derivative, so the first next choice was sulfamethoxazole or sulfonamide and a pyrimethamine. Sulfamethoxazole, why? Because it is longer acting among the sulfonamides. Okay, so sequential blockade we get it, and they are effective against the erythrocytic forms. Okay, so pyrimethamine is a diamino-pyridine. It inhibits the dihydrofolate reductase enzyme. Here, the plus point what they tell is they are tasteless compared to the chloroquine, which has the nasty taste and always causes the nauseating or the vomiting. So it can be used in cases of uncomplicated chloroquine resistant malaria. The dose here you need to remember 1:20. Okay, so you can see here what is the dose difference. Then you need to remember the concentration. Can you get it here? Okay, the double will be 150 milligram. So 150 to 1500, that is 10 times. That means we are using 1:20. Okay. So adverse effects. Why? Megaloblastic thrombocytic cytopenia and agranulocytosis. They are involved in inhibition of the folic acid synthesis. Though the selectivity is there, still they can be affecting the folic acid synthesis. There will be building blocks. They can cause these reactions. So coming to the most important drug, that is the artemisinin derivatives. Okay, they are derived from the plant Artemisia annua. Okay, so they are the active principles. So we have the problem with this artemisinin derivative is the duration of action of these drugs. Okay, the problem, though they are the most effective, and till now we have not got any resistance to these drugs, the most important problem is their duration of action. Okay, so The chemical name cis-butyl lactone derivatives. Okay, cis-butyl lactone derivatives. Most potent, rapidly acting blood saccharides. The short duration of action is the negative point. So poorly soluble in water and oil. Okay, so artesunate is the one which can be made soluble. Okay, artemether, arteether, arterionate. Okay, the duration of action is going on increasing. For example, artesunate acts for around 3 hours. Artemether can extend up to 12 hours, 10 hours. Okay, arteether for 2 days, like that. Okay. Again, the route of administration is a problem there. So now we will try to understand the free radical type of injury as we studied with the prima facie. Okay. So these compounds have presence of endoperoxide bridge. Okay, this endoperoxide bridge, they are acting on, or they interact with the heme part of this parasitic hemoglobin. Okay, so the heme part of the parasite is disturbed, and once this heme part is coming in interaction with this bridge is broken. The bridge, what the endoperoxide bridge, what we tell, which is present in this artemisinin, that bridge is broken down. Once the bridge is broken down, you get a lot of small particles. These small particles are the free radicals. Okay, so these free radicals are the one which can cause the injuries. Okay, so heme iron leaves the endoperoxide bridge. There is generation of highly reactive free radicals which damage the parasitic membrane by covalent binding with the membrane proteins. Okay, so free radical, electrophilic intermediate, all these things is yes. Okay, so here artemisinin is a drug which can cause which can be most commonly asked for the intervals. Okay, so maybe short notes, short answer, or main question. Remember, okay, it can be anything. Artemisinin based therapy can be asked as a main question. So you need to remember a small diagram so that you can impress upon them. Okay, so artemisinin can act on the ring stage and also this, okay, exoelectrolytic state and also erythrocytic state and also the gametocytes. Okay, just remember ring stage, trophozoite and the artemisinin which is acting on the gametocytes. Okay, so all the stages but not the hypnozoite stage. So you need to add the drugs for radical cure. Okay, so mechanism of action here, the second mechanism of action was there. In the plasmodial sarcoplasmic endoplasmic calcium ATPase. Okay, so the endoplasmic calcium ATPase is also affected by this free radicals. So they are water soluble ester of dihydroartemisinin. Okay, so the dose here you need to remember artesunate. Okay, here now what I am telling is for artesunate. Artesunate, remember, act smart and short. Okay, why it is smart? Because it can be given by oral, IM, intravenous, and also rectal. All the possible routes they are tried it. Okay, and it is successful. Okay, so that's why it is smart. But the negative point here is short acting. Okay, 1 to 2 hours, very short acting. Then the dose here is 100 mg twice daily. Okay, that may not be enough. So intravenously they administer the drug again and again. So the next drug, artemether. Okay, artemether, remember, it can be given not by IV. That means what? Not for emergencies. Okay, so it can be given for oral and IM. So for example, when the patient is very, the malaria, though we know that it is a treatable condition, if it is severe, no one can help it. Why? Because the release of toxins and the cardiac toxicity by itself by the parasitic products, where there can be hypotension and all. So artemether given by intramuscular route and oral route. Okay, so conventionally all this artemether, artesunate, all are the prodrugs. Okay, they need to be converted to this dihydroartemisinin. Okay, so once they are converted to dihydroartemisinin, their bridge is there. That bridge again is broken up by reaction with heme. Those the body weight. Okay, so if the person or a patient is around 70 kgs on an average, you need to put it as double. Okay, all the things you can remember. Now with that idea, you see the dosage now. Okay, here you can see. Okay, 100 milligram BD. So that's it. 2.4 milligram per kg, 2.4 milligram per kg. So it is almost double the body weight. Just remember that. Okay, so multiplier again you can see little bit more, that is 3.2 milligram per kg. So RT is the again 3.2 milligram per kg. Okay, the positive point about this RT is it can act for 1 day almost. Okay, once a daily dosage will be enough there. Here it is 3 to 10 hours and half of the day. So RT is the double E is the, remember it can be given only by intramuscular route. So comparatively longer acting drug, but this comparatively longer acting may not be enough to cure it. Okay, we need to add one more drug there. So given intramuscularly, the next drug is articulolol. Okay, again this drug is available only in combination. Recent one. Okay, articulolol. Oral drug it is. So the tablets are available in the form of artesunate and the what? Artemether. Artesunate, artemether is there. But RT is the longer acting one, but only intramuscular. Okay, so adverse effects. Okay, leukopenia, hypersensitivity reactions, J toxicity, ECG changes. Okay, STT, QT prolongation. 90% of these drugs. Okay, except for sulfamethoxazole or paracetamol. So abnormal bleeding, dark urine, reticulocytopenia, all these things are there. So most of the drugs which can cause enzyme inhibition, like okay, so astimazole. What is astimazole? Is it antihistaminic? Okay, read about it. It's an antihistaminic which can be causing this QT prolongation and all. Tricyclic antidepressant, phenothiazines. What are phenothiazines? First generation. Okay. So artemisinin-based therapies, we have already given the idea why we need artemisinin-based therapies and why it also needs the drug which can help it. Okay, so we told that the longest and the shortest they are married together here. Okay, so artemisinin in the methyl. So artemisinin compounds are shorter acting drugs. Monotherapy need to be extended beyond the disappearance of parasite to prevent the recrudescence. That means the hypnozoid work. Okay, this can be prevented by daily regimen. So along with that, we are worried about the resistance. So we add another drug here. Okay, so it can be given only in uncomplicated as a single drug. Otherwise, they are given together. Okay, rapid clinical and parasitical cure is present. High cure rates and low relapse rate once we have used this ACT therapy or artemisinin-based combination therapy. Okay, so we can see that most of the drugs are tried with artesunate because artesunate is smart but shorter acting. Okay, so artemisinin plus mefloquine, piperacillin, artemether plus mefloquine, lumefantrine. Okay, lumefantrine, just remember it is a drug which is never given alone. Okay, it is always in combination with even the drugs. How lumefantrine is available is in combination, not as a single drug. Okay, so then dihydro artemisinin, that is the active product of these drugs. Okay, that can be combined with mefloquine, piperacillin, mefloquinone, all these things are there. Okay, so coming to the prophylaxis and treatment. From here on, I think around 7 or 8 slides are there. Each slide is a short note. Okay, just remember. Each slide is a short notes here. Why? Prophylaxis of malaria, we have toxic chloroquine-based therapy and non-chloroquine-based therapy also. So, okay, how long we give? We start at 1 to 2 weeks before and we give 4 weeks after also. When the person is traveling from a better area to the endemic area. Okay, so chloroquine sensitive malaria, if it is there, that means the area is still not having the chloroquine resistant ones, we can go for the chloroquine drug. 300 milligram Then chloroquine resistance area we can give 250 milligram doxycycline 100 milligram daily, atopic and troponin. That is the enhancing action of troponin. So drugs not only prophylaxis is also important. Okay, so they can ask you for short answers. Okay, so quinine, artemisinin compounds, pyrethrolamine and sulfadoxine and amodiaquine. Okay, these drugs need to be remembered. Okay, these are the bio questions also. Okay, so drugs used in chloroquine resistance. What are the drugs? Mefloquine, quinine. That means there is less of cross resistance there. Okay, sulfadoxine plus pyrethrolamine and the artemisinin compounds. So lumefantrine plus artemether. Okay, we know that these are the drugs available in the combination. So artemether or artesunate derivatives, we just discussed the mechanism. Okay, then lumefantrine we told is a yes. What is lumefantrine's mechanism? I told you don't keep this and sleep. Stand. Mechanism, lumefantrine. Simple question. Lumefantrine mechanism. Yes, Yashas. Shodan. Lumefantrine mechanism. Mechanism. Lumefantrine. Nagesh. Prasad. Lumefantrine, halofantrine, their mechanism is similar to chloroquine. Check. Can't you just read from the board also? And we have given the first slide with the chemozoic formation and we have given 5 years there. No one had time to go home and see what was there. So, mechanism of action is similar to chloroquine. Okay, it affects the second mechanism is it affects the nucleic acid in the protein synthesis of the parasite. Okay, it is a secondary mechanism, not the primary mechanism. So, the one more point you need to remember, fatty food increases the bioavailability. Okay, so peak is in 6 hours and available as a fixed dose combination with artemether. Okay, artemether cannot be given intravenously. So tetracycline, doxycycline. So long duration of treatment commonly used. I will give the dosage regime. Okay. So potent erythrocytic saccharic acid. Okay. In the exams you don't remember anything. Just tell if the drug is it is erythrocytic saccharic acid because it is correct for most of the drug except for it is not also except. Primordial is less effective in erythrocytic, has an erythrocytic saccharic. Other than that, most of them are having the same function. So the beta-mycin, bacteriostatic antibiotic against erythrocytic saccharic. Okay, so tetracyclines are always used in combination with quinine or SP. What is that? Sulfamethoxazole, pyrethrolamine. So they are used when there is chloroquine resistance. Okay, so chloroquine sensitive malaria. What are the common drugs which are used? Okay, so chloroquine 250 milligram tablets are there and they are 150 milligram base. So the drug is given as 4 tablets start, then 2 tablets after 8 hours, then 1 tablet week for 2 days. Okay, so previously we had a strip containing those things. Okay, instead of 4 tablets we have 2 tablets. 2 tablets are placed on either side, rest 4 tablets are in the straight line. Okay, that's how the lateral strips comes. So patient who cannot take orally, we can go for the intramuscular infusions or also IV. Then primordial can be given 15 mg for 14 days for viroxin level, 45 mg for falciparum. Okay, so chloroquine resistant malaria, we can go for pyrethrolamine, sulfadoxine. You need to remember it's a single dose. Okay, this combination is given as a single dose in uncomplicated chloroquine-resistant malaria. Okay, that is one point which can be asked again and again. Followed by quinine can be given, then quinine 600 mg 3 times 23 days, then atopicillin plus proguanil, then 100 mg daily for 3 days. So chloroquine-resistant ones, where they cannot take orally, you can go for quinine 20 mg per kg in divided doses in dextrose. Okay. To remember any other drugs which can be given only in dextrose. Find it. Okay. One is this quinine. We also told that one of the side effects of this in malaria is the patient can get hypoglycemia also. So can also go for artemether injections. So complicated, we need to go for artemisinin derivatives. Okay, artesunate, artemether, arteether, all these things in divided doses. Remember, twice the body weight. In artesunate, almost thrice in case of artemether and arteether. So complicated, we can cerebral type. We can go for this quinine and its derivatives. So the next important part is malaria in children. Okay, what can be given, which is not there, but still we discussed what was the drug. The popular trade name is Cetran. Okay, pyrimethamine, sulfamethoxazole, we told that they do not give the taste or the toxic taste of this chloroquine. That's why it can be. So along with that, we can also think of this quinine, primaquine, and so not mefloquine. Okay, if it is below 15 kg, that means baby is less than 3 years, we cannot go for this. So primaquine is avoided, and except for this,